Hello, my fellow colleagues, interns, residents, aspiring doctors, and cardiology fellows aspiring to take the boards, and of course, others who are not doctors. Welcome to the Cardio 360 video series on my website, MuniMeterHealth.com, which is featuring on Facebook as well as on YouTube together. I'm Dr. Jaitly from New York. Here I am talking to you about where do you need the device therapy in which heart failure patients. It's a commonly asked question on the exams. It's a commonly asked question within your clinical practice. So the consultants would commonly be faced with this when they're consulting in this ICU, CC, or wherever, maybe in the cardiology clinics as well, within the hospitals or at their offices, because that's a common concern. And we know heart failure is an ever-increasing epidemic, as we know. I always remind myself when I was talking to my medical students during the lecture series, I used to tell them, I said, look, we're not dying of ailing hearts anymore. We are dying of failing hearts. So we are living longer, but unfortunately the hearts are now failing. So that's what is happening, and the longer we live. Anyway, that's the longer survival pattern we have developed, but unfortunately we also have failed hearts, if you will. So that's increasing prevalence, increasing incidence, as we know. Okay, within this video, a quick clip, I just want to delve on the facts that we know the heart failure, based on an echo, it'll look like this, obviously. The RA and RV is here, and LA and LV is here, because the heart is now inversely represented on an echo, mainly for the students, because I'm sure the others, they already know it. Now, if invariably one comes across a bundle branch in many of the heart failure patients, so there is an interventricular conduction delay. Now, the moment you have a bundle branch block, specifically so if it's a left bundle branch, the chances are you will have a huge amount of dyssynchrony besides the left ventricle being weak as is. So when you have a cardiomyopathic heart, whether it's ischemic or non-ischemic, regardless, but then you also have a dyssynchrony because remember, septum is contributing to some degree to this ejection fraction, whether it's a regional or global ejection fraction, whatever numbers you look at. So the chances are that you are having this dyssynchrony, which means that it's participating in a right ventricular contractility, if you will. That's why I've shown these green arrows here. So the ventricle contracts, but then the septum thinks, let me aid the right ventricle instead of the left ventricle. So the ejection fraction even further suffers in a setting where there is septal dyskinesia, as I've shown it here. So that's a typical heart failure with bundle branch. Now let's understand what are the indications for a simple ICD first, and then we'll go to the biventricular pacing here. So on my left panel, I'm defining how the ICD works. The ICD normally has two, what you may call leads, and one lead stops right here in the right atrium area, mainly for atrial pacing, so this way you can have a nice AV sequential pacing if need be. And then, of course, the second lead goes down to the right ventricular apex. So that stimulates it, so this way you will have a constant pacing and a cardioverting and a defibrillation modes available through this generator, which is placed under the skin right below the clavicle in the subclavicular fossa. Having said that, now what are the indications here? Now in simple terms, obviously the heart has to be functioning less than the normal range. We know the normal ejection fraction is about 55, but the clinical trials have shown that less than 55 doesn't cut it. We need to get it to less than 35 in order to qualify for a device. So in order to have an ejection fraction, in order to have a device placed, then you have to demonstrate the ejection fraction is less than 35%. Patients have to be dyspneic at class 2 or 3. That means for minimal activity or moderate activity, they should still be dyspneic. And this is despite maximum regimens of heart failure, which is including now, I believe, now all these guidelines were made prior to the neprilysin inhibitors that came in, and prior to the ivabradine that came in. Those are the two new drugs that came in only recently in the past couple of years. So just remember that. But beta blockers, ACE, ARBs, diuretics, in the nitrates and hydralazine, all of them have been included, and these maximized regimen tolerated therapy, including aldosterone antagonists. So when it says maximized regimen, it must include trials with all the rest of the therapies first, where they fail and the patients are still enough dyspneic to qualify for this ICD placement. Okay, so far? Good. I know there's a lot of information, but this is really hardcore cardiology right now. We're getting into in these 5 to 7 minutes of my video minutes. It's very helpful right before you take the exam the next day or the same day. Now, episodes of sudden cardiac death or fatal refractory ventricular arrhythmias, for instance, if somebody has had VTs, obviously ICD will immediately abort that. So once you have that device placed in, this pacing wire will immediately attenuate that ventricular arrhythmia that is incessant or persistent there or recurrent. A secondary prevention also is a good idea here. Why? Because you certainly want to make sure that these patients do not undergo the sudden cardiac death episodes again and again. So it's primarily for that reason they qualify for that. And of course, you have to demonstrate that the survival pattern is at least 1 year. Because what's the sense in putting in ICD, which costs tremendously, big tax dollars amounts? We need to ascertain, and the clinical trials have clearly shown that if you have a survival pattern of at least a year, then you can define some bigger longevity and the p-values and all those things within the clinical trials have been suggested that, look, you need to get at least a survival of 1 year in these patients estimated first before you even consider placing an ICD. Now, let's shift to the right side of the panel, which will define what the cardiac resynchronization therapy is, also called biventricular pacing. So when is the biventricular pacing required? Well, biventricular pacing is required in this setting with heart failure with bundle branches, where you have a septal dyskinesia, and as a result, this septum is moving into the right ventricle during the time it's contracting and it's not participating like into a left ventricle. It's participating more like a right ventricle. Get it? All right, so now you have 3 leads. Instead of 2 leads here on the ICD, you have 3 leads. Now you wonder why. Well, let's see now. The one lead goes into the right atrium, just like this one here. So right atrial pacing begins here. So that keeps the AV sequential pacing going. The second lead goes into the right ventricle. At the apex here, it's nicely lodged. So this way you could pace the entire heart and right ventricular pacing is done. And the third is going via the coronary sinus. That's interesting. Coronary sinus, and it travels into the left ventricular apex. You see this one? So this is the third pacing wire, which is now sitting in the left ventricle, and that paces from the left free wall, if you will, left free wall. So now you have the synchrony going between the right ventricle and the left ventricle at the level of near physiology, if you will, because we know which bundle travels faster than the other. Normally, it's the left side is stimulated than the right stimulus. So left bundle travels faster than the right bundle. The electrical impulse travels like that, even a microsecond difference. So that is being restored via this generator that's being applied, and obviously now you have electrophysiologists and the cardiac surgeons and cardiologists like myself. We will be involved in making that decision at the generator level and wanting to make sure that this is nicely synchronized before the patient is discharged home. Okay? So heart failure with bundle branch blocks receive cardiac resynchronization therapy. However, the indications still remain the same. The hemodynamic instability. Patients are markedly functionally incapacitated. That means they have class 3 or class 4. By the way, CRT is not indicated in class 1 and 2 yet. Clinical trials are ongoing right now. But class 3 and 4, it's clearly indicated by ACC. QRS have to be prolonged beyond 0.12 seconds, as I said, or a left bundle branch is present. And of course, the ejection fraction is still the 35% or less, and you have to have a survival pattern of more than a year, as I said earlier, for the ICD. So rest of the indications remain the same, except that QRS is more than 0.12 for a bundle branch. So the trick question is, if a heart failure is present without the bundle branch, what would you give you? What would you like to give to that patient? A plain ICD. But if the heart failure was present with the bundle branch block and you had a QRS 0.12 and above, or a left bundle branch if they show you on the exam, give the person a CRT, because you want to have these two walls synchronized well and let the septum participate like a left ventricular wall rather than a right ventricular wall. Any questions? Okay, good. Now go back and study more in the text and in your journals and supplement the information, of course. And so that was a quick nutshell on this which heart failure patients qualify for device therapy in this video vignette. I thank you so much for your attention and looking forward to meeting you again. All right, this is Dr. Jaitly from MuniMeterHealth.com. Keep watching and stay healthy. Bye.